Today we're going to discuss the cognitive symptoms of dementia. In previous parts, we've discussed the typical assessment of a patient with dementia, how the brain works, and common neuropsychiatric disorders. Dementia is one of the more common neuropsychiatric disorders. In this segment, we'll talk about the cognitive manifestations of these diseases. The objectives of this talk include, number one, to define dementia. Number two, to list the four most common types of dementia in the elderly. Bearing in mind the fact that there are many different types of dementia, you need to know the most common ones. Number three, explain the clinical manifestations and neuropathology of amnesia, aphasia, apraxia, and agnosia, the four most common clinical manifestations of dementia. And finally, we want you to describe the natural history of dementia and Alzheimer's disease. In other words, what happens to a patient over time who suffers from these disorders. Previously, we've discussed the 3 Ds of geriatric neuropsychiatry. We've talked about delirium and depression. We only briefly touched on dementia, so today we're going to focus on that particular subject. These issues are very important to those of you who work in the long-term care industry. We know that, for instance, 80% of individuals residing in nursing homes suffer from a mental illness, 60% of whom are demented. We also know that anywhere between 40 and 50% of people residing in group homes or assisted living facilities also suffer from some neuropsychiatric disorder. Anyone working in the long-term care industry needs to know about dementia as well as other neuropsychiatric disorders. What is dementia? Well, it comes from the Latin term de, out of, or mens, mind. In other words, you're out of your mind. And what it really means is the loss of multiple intellectual functions over time in an awake state. If a patient is in a coma, we don't really say that they're demented, but rather that they are in a coma. Let's review some of the things that we discussed in the section on brain function. First of all information is stored on neurons, as depicted in this picture of an individual neuron. You're born with 13 billion neurons. They do not reproduce. When they die, they are gone. They are not replaced, and the information which is stored on them is erased. It's important to keep in mind that the essence of dementia is the death of these brain cells. And this is manifest, as seen here in these pictures, by the loss of brain tissue and shrinkage. On the left, you see a normal brain, and on the right, you see a patient with Alzheimer's disease. Note how decreased in size the brain volume is. This is the result of the death of brain cells. In the next slide, we see 3 different brains. On the left, on the far left, is a normal brain. In the middle is the brain from an individual who was demented over a period of 3 to 4 years. And to the far right, you see a brain from an individual who had been demented for over 10 years. Notice how there is a consistent reduction in volume. So in addition to having brain cells die, they die in a progressive manner, which mirrors the progressive loss of cognitive function. Not all brain cells die in every brain. Here we see a brain of a patient with Alzheimer's disease. And in this area here, you can see that there is considerable shrinkage. This is the parietal lobe that governs things like ADLs. Over here, however, as depicted by the arrow, you can see that there's relatively little shrinkage. This is the occipital lobe that governs vision. So this patient, for instance, may no longer be able to do ADLs like dressing or bathing, but on the other hand, they still may be able to visually recognize things. Again, one area for ADLs, the other area for vision. The ADL area is atrophic, the visual area is not. You lose ADL functions, but visual function may remain intact. Different parts of the brain dying at different speeds. A progressive, relentless death of brain cells. This is the essence of dementia. It's important to know about dementia because it's an expensive disease. On the next graphic, for instance, you see the overall cost in 1995. In Alabama, it cost the taxpayers about $500 million per year in both direct cost of care for the dementia victim as well as indirect cost from lost wages for the caregivers. In the United States, the cost of dementia care, both direct and indirect, totals about $80 billion, that's billion with a B, per year. These numbers will rise dramatically over the next 20 to 30 years as the number of individuals over 85 grow in our country. If you're going to look at a patient with dementia and try to manage them, it's important for you to conceptualize the disease as containing two different components, cognitive and psychiatric. You have to understand the cognitive deficits as well as the psychiatric symptoms associated with dementia. In this segment, we're going to talk primarily about cognitive deficits. In a second segment, we're going to talk about psychiatric symptoms, and when these cognitive and psychiatric symptoms come together, they often result in behavioral manifestations, which will be discussed in a third segment. What are the cognitive symptoms and the basic principles of cognitive loss associated with dementia? Well, first of all, no pattern of intellectual loss is specific for any particular type of disease. You can't look at a patient and say, well, he's got memory problems, therefore he must have Alzheimer's, as opposed to vascular dementia or Pick's disease. The pattern of loss differs for each person. No two patients are the same, so you can't get a prototypic Alzheimer patient in your mind and then expect every other patient to look the same. The speed of loss is variable. Some patients progress very rapidly, so over a period of 3 to 4 years, they lose most of their basic intellectual functions. On the other hand, some patients drift downward very, very slowly, and after 10 or 15 years are still able to do most of their activities of daily living. The speed of loss of function, like the speed of death of brain cells, is variable from individual to individual. Cognitive loss is cumulative over time. That is, the longer that you live with most types of dementia, the more cognitive impairment you're going to experience. Dementia is a common disease. 10% of people over the age of 65 have cognitive impairment. 47% of those over age 85 are cognitively impaired. And remember, in the aging section, we discussed the fact that individuals over the age of 85 are the single fastest demographic subgroup in our country. Moreover, dementia is an equal opportunity afflictor. There are no racial differences in the manifestation of this disease. When we talk about the diagnosis of dementia, a good clinical history and good clinical evaluation is the basis of making the diagnosis. We talked about that in our assessment section previously. As you see in the next graphic, both the sensitivity and the specificity of the more commonly used systems of diagnosis, whether it be the DSM, NINCDS, or the ADRDA, is relatively high, anywhere between 70 and 90% for both sensitivity and specificity. The take-home message is if you do a good clinical history and a good clinical evaluation, the chances are about 9 out of 10 that you will arrive at a proper diagnosis. What are the 4 common causes of dementia? Well, the first and most common is Alzheimer's disease, which accounts for about 60% of all dementia. Vascular dementia, which previously was thought to be the most common, actually only accounts for about 20%. This is the old hardening of the arteries. Back in the 50s and the 60s, everybody who lost their intellectual abilities over age 65 was said to have, quotes, hardening of the arteries. Well, we now know that only about 20% of individuals with dementia actually have vascular dementia. Alcoholic dementia is probably the third most common, accounting for anywhere between 2 and 10% of all cognitive loss. And a new disease called diffuse Lewy body disease, which we won't have time to talk about today, accounts for probably the 4th leading chunk of dementia. If you're going to talk about dementia, then in most instances you're going to be talking about Alzheimer's disease. If you want to understand the cognitive symptoms of Alzheimer's disease, you have to know the 4 A's of Alzheimer's disease: amnesia, aphasia, apraxia, and agnosia. If you don't know the 4 A's of Alzheimer's disease, you will be constantly baffled by your patient's symptoms. You will be treating cognitive symptoms like psychiatric symptoms, and you'll have great difficulty in explaining the problems that your patient's experiencing to either the family or the CNAs who are caring for the patient in the nursing home. The 4 A's of Alzheimer's disease: amnesia, aphasia, apraxia, and agnosia. Let's begin by talking about amnesia. What is amnesia? It is the inability to remember facts or events. Remember when we were talking in the brain functions section of this series, we said that there were 2 types of memory, recent and remote. Just to remind you, recent memory is what you ate for breakfast. It's things that happened 5 or 10 minutes ago. Remote memory is those things that you have stored on your hard disk. Things like the appearance of your childhood home, what your high school graduation was like. These are things that are stored over long periods of time. Recent and remote memory are important because they operate in 2 different areas of the brain, and they are preferentially damaged in Alzheimer's disease. This is the temporal lobe on top of a normal individual. Below is the temporal lobe of a patient with Alzheimer's disease. The arrow points to the part of the brain called the hippocampus. Here up above you can see it has a normal volume. Down below the arrow points to the Alzheimer hippocampus, and notice how shrunken it is. In fact, it is so shrunken that the ventricle, the fluid-filled cavity, as outlined here by this arrow, is markedly dilated in comparison to the crescent-shaped ventricle up above. What does the hippocampus do for you? Well, the hippocampus is the gateway to recent memory. So if this part of the brain is damaged in Alzheimer's disease, the patient can no longer remember things that happened 5 or 10 minutes ago. Yet remote memory is stored elsewhere and is damaged later in the disease. This is the typical patient in a nursing home who's draped over the nursing station, asking the same question over and over again. Is my wife coming? Is my wife coming? The staff takes the person back to his chair and says, no, your wife isn't coming today, they're coming on Wednesday. 5 minutes later, the patient pops back up and is back at the nursing station. After a while, the staff begins to become aggravated by this patient's behavior, because as the patient is being taken back to his chair, that patient is explaining everything that happened 15 years ago at the family picnic. After a while, the staff says to themselves, well, if he can remember what happened 15 years ago, why can't he just remember what I told him 15 minutes ago about his wife coming? Eventually, they decide that the patient is actually stubborn and mean and ask for antipsychotic medications, when in fact the patient's hippocampus is severely atrophic and he can't remember what happened or what was told to him 15 minutes ago, because that circuit has been erased by the disease. He is living in the past because he cannot remember the present. This is the typical type of amnesia that you see in Alzheimer's disease. Eventually, remote memory is damaged as well, and in a separate segment, we will discuss what end-stage memory impairment looks like in Alzheimer patients. Next, we're going to talk about communication problems in Alzheimer's disease. Before we talk about what goes wrong, let's talk and review a little bit about channels of human communication. Remember in the brain function section, we talked about how the processing of auditory information occurs in the brain, that there are different parts of the brain that interpret the meaning of words, the tone of voice, body language, and facial expression. Each one of those different functions is stored and recorded in a different part of the brain. Aphasia is the inability to understand or to communicate with either spoken or written word. There are 2 different types of aphasia, receptive or expressive. Aphasia is fairly common in Alzheimer's disease, and aside from amnesia is the second most common symptom that you'll see in the patients. Usually it occurs in the mid-stages of the disease. Let's begin by talking about expressive aphasia. This is the inability to communicate with others, either through spoken word or through writing. On the left-hand side of your screen, you see a normal section through the frontal lobe. On the right-hand side of your screen, you see the shrunken, atrophic brain of a patient with Alzheimer's disease. This cut is squarely through the part of the brain that is involved with the construction of speech or talking. It is damaged frequently in patients with Alzheimer's disease who then struggle to find the word that they want to say or have difficulty constructing sentences. What is it like to have this kind of difficulty? Well, think of the last time you had a word stuck on the tip of your tongue. This is what it's like to have Alzheimer's disease. Only instead of having one word stuck on the tip of your tongue, every third or fourth word is stuck on the tip of your tongue. You can see how frustrating it would be for the patient with Alzheimer's disease or any other type of dementia, because both amnesia and aphasia are common to most types of dementia. Expressive function, remember, is primarily constructed on the left side of your brain. That's where words and grammar are constructed. On the right side of your brain, however, is emotional quality, musical tone to the voice, in other words, the musical pitch and intonation of the voice, as well as cursing. So it's possible to have heavy left-sided damage and not be able to speak well, but still have your right side intact and be able to curse. Oftentimes, families or staff will see a patient who has great difficulty in saying what he means, but then on the other hand has no difficulty cursing or hollering. And they infer that because they can curse or scream that they must be able to speak. It doesn't work like that. Left side is grammar, right side is music and cursing. Different sides do different things, different functions are lost at different speeds. Receptive aphasia is the inability to understand spoken word. This is a common problem in patients with Alzheimer's disease, and they usually cover it up, so it's hard to know whether they understand what you're saying to them or they don't. Here you see two brains. On top is the normal, down below is the Alzheimer's. The frontal lobe is involved with the expressive or talking function. The temporal lobe is designated as the hearing area, and that is involved with receptive function. On the left, we see a normal temporal lobe, and on the right, we see a temporal lobe from a patient with Alzheimer's disease. This is typical of the type of significant pathology that occurs in the brain region that interprets spoken word. Now, Alzheimer's disease is a tricky disorder in that it does not damage the part of the brain, as designated here, that is involved with the primary sensory function. In other words, the ability to hear is not damaged by this disease because the neurons that receive the auditory impulses are not damaged by the Alzheimer process. On the other hand, the association cortex, as designated here with the arrows, is severely damaged by the disease. So what you're left with is a patient who can hear but cannot understand because of the selective type of atrophy that occurs in patients with Alzheimer's disease. Let's take a practical example. This is the elderly individual who's in the nursing home, and the nursing aide has come in to get him up to take a bath. Well, this individual has Alzheimer's disease and receptive aphasia, but as is often the case, the staff doesn't know that he doesn't understand spoken word. So that staff person walks into the room and says to Mr. Jones, time to take your bath, take off your pajamas, put on your robe, and come on down the hall and I'll help you take your bath. Well, Mr. Jones, who has both amnesia and aphasia, can't remember who this fellow is or why he's in that nursing home and doesn't understand a word that's been said to him. But the fellow is being pleasant to him because he can tell based on his visual cueing, so he says, okay, fine. Well, the nursing assistant comes back 10 minutes later, and there's Mr. Jones still fully dressed. Well, the nursing assistant, who now is late, assumes that Mr. Jones is, quote, being resistive. So he comes over and he grabs a hold of Mr. Jones and he says, come on, Mr. Jones, we need to take that bath now. Well, Mr. Jones still doesn't know who this fellow is and still doesn't understand what's being said to him, but he sure does get the tone of voice, and he does understand the body language and the irritation that is visible in this man. Now let me ask you this. If a perfect stranger walked into your room in the morning, started speaking to you in an angry tone of voice, and tried to take your clothes off, what would you do? Would you disrobe or would you fight? Well, of course, Mr. Jones, just like the rest of us, is going to fight. And as soon as that happens, he's labeled as a, quote, behavior problem, and he gets all sorts of psychotropic medications that are going to cause him to fall and to not want to get out of bed in the morning. When in fact, Mr. Jones only has a cognitive impairment, and that other means should be used to communicate with him, such as visual cues, one-step commands, using simple words and phrases, and always, always keeping a smile on your face and speaking in a calm, steady, friendly tone. This is receptive aphasia. It's fairly common in Alzheimer's disease. When it's misdiagnosed or unrecognized, it can lead to confrontations between either family or staff and the patients. The next of the four A's that we're going to talk about is apraxia. Apraxia is the inability to do pre-programmed motor tasks. When you got up this morning, you didn't need a set of instructions on how to shave, brush your teeth, or put your clothing on. You knew how to do that because many years ago your parents taught you how to do that. And when they were teaching it to you, they were programming your brain. And that's stored in specific brain regions, specifically the parietal lobe. When that part of your brain is damaged by the disease, then you will lose those functions. And as you lose those functions, you develop what we call apraxias. On the left is a section through the coronal plane of a normal elderly individual. On the right is the same level through a patient with Alzheimer's disease. Note the difference in size and the diminished volume of the cortical ribbon. This is typical of the changes seen in Alzheimer's disease, typical of the parietal lobe atrophy. Remember, that's the part of your brain that governs many of your ADL functions, that is, activities of daily living. Here's a lateral view of a patient with Alzheimer's disease. Notice the frontal lobes as designated here by the arrow. See how shrunken they are. But the motor strip right here, as designated by the star, is not as shrunken. And in fact, if we make a higher power of this, you can see over here, as designated by the arrow, that the motor strip is relatively intact. This is where the neurons that move the arms and the legs are located. Over here in the parietal lobe is the area that tells the arms and legs what to do. For instance, how to put your hand through the shirt sleeve, how to put your pants on, how to use a razor. So it's possible to have the ability to move your arms and your legs and not know what to do with them because the part of the brain that stores those sophisticated programs is erased by the disease, but the parts of the brain, the neurons that move the arms and legs, are relatively spared. Here's a different part of your brain that actually governs the movement of your foot and your legs. Over here to the side, as designated by the arrow, is the association cortex that stores sophisticated programs, but here, as designated by the second arrow, is where the primary motor cortex is. This would be a patient who could move their legs but wouldn't know what to do with them once they began to move. This is called a gait apraxia. This is the typical patient who can kick at you and swing their legs over the bed rail to climb out of bed, but as soon as they try to stand up, they don't know what to do with their feet underneath them, and they may fall or walk in a stiff gait, almost like they were on rollerblades. And in fact, it does feel just like being on rollerblades to them, because when we get up on rollerblades, if we haven't been trained, we don't know what to do with our feet, do we? Well, the same thing happens to patients who are walking with Alzheimer's disease who have forgotten how to walk. This is called a gait apraxia, and it's fairly common in advanced stages of Alzheimer's disease. And we'll talk about this in the end-of-life segment. Agnosia is the inability to recognize previously learned sensory inputs. On the left is an occipital lobe from a patient with Alzheimer's disease. On the right is a normal occipital lobe. Notice how atrophic that occipital lobe is. What does this part of your brain do? It stores visual impulses. For instance, if your wife or your husband or your child were to walk into the room, you'd know instantly who they are. How is that? How can that be done? Well, your brain has a filing cabinet filled with visual images. And when you see a face, your brain goes rummaging through that filing cabinet until it comes up with the correct picture. Once it's identified the name, then it goes into its longitudinal file to determine the life history for that person. So if you recognize the face, then you go into your temporal parietal cortex and remember that, yes, this is my wife, and she went to college at this time and in this place, and we've had 3 children together. These visual images are stored in your occipital lobe. as this part of your brain begins to die, you lose the ability to remember faces and objects. This is the typical patient who can no longer remember the face of their caregiver, even though they may be able to give detailed history about the caregiver. It's very frustrating to that individual because the caregiver says, if they know all about me, why can't they recognize me? And the answer is because the part of the brain that stores and retrieves visual images has been damaged by the disease. These are the 4 A's of Alzheimer's disease. Actually, these 4 A's are found in most types of dementia: amnesia, aphasia, apraxia, and agnosia. If you're not familiar with those 4 A's, you cannot manage the typical patient with Alzheimer's disease. Why are these parts of your brains dying? If we were to look under the microscope, what sort of changes would we see? Well, let's move on to talk about microscopic brain changes in Alzheimer's disease. And this is very specific for Alzheimer's. Other types of dementia have other microscopic alterations. The pathological hallmarks of Alzheimer's disease are senile plaques, neurofibrillary tangles, and amyloid deposits. Let's begin by talking about senile plaques. Here we see a picture that depicts the microscopic appearance of a senile plaque. Off to the side in this silver stain is normal neuropil. Neuropil is the woven substance of the brain tissue. It has this sort of light honey brown appearance on this slide. In the center you see this massive debris. This is a senile plaque. We don't know what causes them, and we're not completely sure whether it's degenerative or regenerative processes. We know that they are found in great abundance in patients with Alzheimer's disease, but we also know that there are some normal elderly people who have some senile plaques as well. This is a low-power microscopic picture of a brain of an elderly individual. Here you see 1 or 2 senile plaques as depicted by the arrows. On the other hand, on a section from the Alzheimer brain depicts scores of senile plaques. And in fact, it looks almost like it's been birdshot with senile plaques. In fact, we make the diagnosis of Alzheimer's disease based on the densities of these senile plaques. Next, this is the appearance of a neurofibrillary tangle. This flame-shaped mass of filamentous material that exists within the individual nerve cells indicates that this nerve cell is terminally damaged. To the side, as depicted here by the arrow, is the appearance of a normal-looking neuron, which is faintly seen under this silver stain. There are actually several neurofibrillary tangles on this slide. This is amyloid deposition within the brain tissue. The circular structure in the middle is a blood vessel, and this brown, fluffy material surrounding it is amyloid, proteinaceous material that is deposited in high densities in the brains of patients with Alzheimer's disease. This same material is also found in the center of senile plaques. Some people think that it's toxic in the brain. This will be discussed in a separate segment discussing research initiatives on the causes of Alzheimer's disease. But suffices to say, it's abnormal. It's never seen in the brains of younger individuals. What are some of the risk factors for developing Alzheimer's disease then? When your patients come in and say, am I at risk for developing Alzheimer's, what are some of the things that you should be looking for in your clinical histories? And again, this is specific for Alzheimer's. Vascular dementia, diffuse Lewy body disease, they each have different types of risk factors. But for Alzheimer's disease, it's age, family history, a history of Down syndrome, trisomy 21, and a specific marker called ApoE. And the specific type that you would look for is what's called ApoE type 4. What are some possible risk factors for Alzheimer's disease? Well, in the causative column, head trauma may be associated with Alzheimer's disease, as well as advanced maternal age. In other words, the older your mother is, the slightly higher chance you have for developing Alzheimer's. And there is some literature to suggest that people with less education may have less intellectual reserve and be at slightly higher risk for developing the disease. Protective factors include smoking, curiously enough, although we don't encourage people to smoke, anti-inflammatory medications such as Motrin, which may help dampen some of the inflammatory response in the brain, and estrogen therapy. In conclusion, then, what are some of the risk factors? Heredity. We know that 5% of Alzheimer's disease is inherited as an autosomal dominant. 20 to 60% of Alzheimer's disease has a significant genetic predisposition. It may be an autosomal dominant with age-dependent penetrance. And aging. 10% of people over age 65 have it, and 47% over 85. So consequently, the more family members that you have and the older that you are, the greater your risk for developing Alzheimer's disease. It's important to remember that Alzheimer's disease is a progressive disorder. There are different staging mechanisms for Alzheimer's disease. Some people divide it into 3 stages, other people divide it into 7 stages. I like the simpler staging system, which is early, middle, and late. The average life expectancy of a patient with Alzheimer's disease is 7 to 10 years. We can divide it into 3 stages, early, middle, and late. Early lasts about 2 to 3 years and usually is associated with amnesia and some language problems. Middle stages also last anywhere between 3 and 5 years. And in the middle stages, the patients develop all 4 A's, amnesia, aphasia, apraxia, and agnosia. In addition to that, they develop most of the psychiatric manifestations. The late stages, there is advanced brain disease, and patients develop overwhelming cognitive impairment. These late stages and their clinical management will be discussed in a subsequent section on end-of-life issues in Alzheimer's disease. It's important to remember that Alzheimer's disease only afflicts the brain and not the body. There is no other organ system that is damaged by this disease. That's why these patients, quotes, look so healthy and live so long, because all of their other organ systems are unafflicted by the disease. However, these patients do die from the complications of Alzheimer's disease, usually pneumonia or urosepsis. Is it possible to predict how rapidly a patient is going to lose their intellectual abilities? Well, some people think that there may be some ways of predicting. A few of the factors to take into account is, first of all, premorbid intellectual function. Patients who started off with less intellectual reserve probably have a more rapid intellectual decline. High intellect, high functioning individuals probably have a more gentle decline. Age of onset. Patients with early onset dementia, that is occurring before the age of 65, tend to have a more rapid and perhaps more malignant course. They also tend to have more psychiatric manifestations. Patients who develop Alzheimer's disease over the age of 75 tend to have somewhat of a gentle, slow decline. ApoE typing. If you have bad ApoE, if you have a double dose of bad ApoE, that's ApoE4, then you have probably an increased risk for having a more rapid decline. And medical interventions. And what I mean by this is if you have a lot of medical problems that cause you to become physically and psychiatrically stressed and distressed, then the probability is that your decline will be more rapid than those who are otherwise physically healthy. What are the chemical deficits that are associated with Alzheimer's disease? And again, here we're only talking about Alzheimer's disease. Diffuse Lewy body disease and alcoholic dementia and vascular dementia have different chemical deficits. But since Alzheimer's disease is the most common type of dementia, let's talk about the chemical deficits that we see. We know that patients with Alzheimer's disease have significant loss of acetylcholine in their brain. In addition to that, they have loss of norepinephrine, serotonin, and a variety of other transmitters to include peptides, the GABAergic system, as well as many others. Why is it that these people lose acetylcholine, and why is it so important? Well, here we see a cartoon. On the left is a brain of a patient with Alzheimer's, and on the right is a normal individual who's at the same age. The NBM stands for nucleus basalis of Minard, which is that gray matter that sits right beneath that white matter tract as depicted here by the arrow. The nucleus basalis of Minard is the head cholinergic nucleus for the brain. It is selectively and severely damaged in Alzheimer's disease, which is why patients with Alzheimer's disease develop a cholinergic deficit. That is why patients with Alzheimer's disease are so exquisitely sensitive to the confusing effect of drugs with anticholinergic side effects. And that is also why the drug companies are crafting medications that increase the amount of acetylcholine, because they're trying to tweak the function of the remaining nerve cells in this brain area. It's also important to keep in mind, however, that although acetylcholine is lost early and is lost consistently in Alzheimer's disease, you're losing many other chemical transmitters. Why is that? Well, other brain regions are also dying. For instance, on the left is a normal brainstem. On the right is the brainstem of a patient with Alzheimer's disease. Notice how shrunken and reduced in volume the Alzheimer brainstem is. This is where nerve cells are present that produce a wide range of catecholamines. On top, we see a normal pons in normal midbrain from an elderly individual. Below, we see that of an Alzheimer's disease patient. Above, the arrow points to the locus ceruleus, that brown pigmented area immediately adjacent to the cerebral aqueduct. Below, the arrow points to where the locus ceruleus used to be. It's gone because the neurons of the locus ceruleus have been killed by the Alzheimer's disease process, resulting in a deficit of norepinephrine. On the right side, you see the normal substantia nigra as depicted by the arrow. Below, in the Alzheimer's substantia nigra, you see that the nerve cells are depleted and it's become pale. Consequently, as a result of this brainstem injury, the Alzheimer patient has not only lost cholinergic cells, but also cells that produce norepinephrine, dopamine, and serotonin. Patients with Alzheimer's disease are losing a range of transmitter systems. That's why simply replacing one chemical transmitter is not going to fix the broken brain of a patient with Alzheimer's disease. But in addition to Alzheimer's disease, 20% of patients have vascular dementia. We're not going to have time to talk about vascular dementia in this segment, although it is discussed in a separate segment. It is important to remember, however, that patients with vascular dementia usually have focal neurological signs, an upgoing toe, weakness, a drooping face, typical of the strokes that exist in these patients' brains. And likewise, patients with vascular dementia generally have some sort of causative stroke. That is, that when you scan them, you can demonstrate some sort of infarction in the brain. Vascular dementia accounts for 20% of all dementia and is probably the second most common cause of cognitive decline in the elderly. What can we do then to sustain cognitive function in patients with dementia? Well, first of all, we can attempt to retrain them in simple basic things, simple basic skills that they may lose. For instance, if they go to the hospital to have a hip fracture fixed or have their pneumonia treated. When they return from the hospital, they may not be functioning at the same level as when they went to the hospital, and those individuals can probably be retrained and can regain a little bit of that function. The idea is to keep them independent and functioning for as long as possible. The second thing that you can do is medication therapy. There are medications that increase the amount of acetylcholine in your brain, specifically Aricept. This is a medication, however, that is only helpful for patients in the mild to moderate stages of the disease. Aricept is effective for patients with Folstein Mini-Mental scores 15 and above. Patients in the 15 to 10 range probably are not going to respond to Aricept. Those below 10 probably will not respond to Aricept, and those drugs should not be tried on profoundly demented patients without consultation with an expert who has treated many of these patients. Cognex is a second drug that sometimes is used to increase acetylcholine in the brain. However, it has a variety of side effects and a difficult dosing schedule. Aricept is easier and safer to use in patients with dementia. Sometimes you can help sustain cognitive function simply by discontinuing medicines that cause confusion. Drugs like antihistamine, Benadryl, Vistaril, drugs with anticholinergic side effects like Elavil, or benzodiazepines like Valium and Librium contribute to patients' confusion and memory impairment. Discontinuing medication can sometimes help. And management of associated problems. For instance, if the patient develops depression, and we're going to talk about that in a subsequent segment, treating that depression may help actually improve the patient's cognitive function. Likewise, if the patient is chronically hypoxic, then treating their hypoxia may help their cognitive function. These are some of the things that you should think about in your Alzheimer patient to help sustain and maybe even slightly improve some of their cognitive function. It's important to remember, however, that the underlying process here is dying brain. Nothing will stop their brain from dying. So eventually they are going to lose function and they're going to succumb to the disease. In closing, it's important to remember that patients with Alzheimer's disease also have psychiatric symptoms. 30 to 40% develop psychosis, either hallucinations or delusions. 25% develop depression. In addition to that, they become irritable, manifest poor judgment, have inappropriate behavior, and have major personality changes. These issues are discussed in a subsequent section that gives a detailed description of the types of psychiatric and behavioral manifestations that you can expect to see in patients with Alzheimer's disease. In conclusion, dementia is the loss of multiple intellectual functions over time. If you're going to effectively care for patients with dementia, you must understand the 4 A's: amnesia, aphasia, apraxia, and agnosia.